Hi, I'm Sanchita. I'm the director at the British Institute of Human Rights, a small but perfectly formed charity working across the whole of the UK, supporting people and groups and frontline staff to really think about how they can use human rights for social change. And I wanted to do what I think is probably my first vlog this morning, as today we saw the Care Quality Commission release its report on do not resuscitate decisions during the pandemic. It's focused kind of particularly on do not attempt resuscitation decisions around people with learning disabilities and older people, and finding some what should be really shocking results from the research that they have conducted, the review that they've undertaken. But for those of us who work consistently in the health and social care sector, social work sector, and more importantly for the people who are in those services, accessing them or trying to access them, and their families and their supporters, we know that the issue of discriminatory use of do not resuscitate orders is an everyday one. We know that there is significant use of these decisions, sometimes called orders, but essentially a decision which will prevent somebody from receiving potentially life-saving treatment, and that this is happening on the basis of people's disability, often kind of around learning disability, but we see it also in relation to physical disability and in relation to children, working age people and older people as well. And I think that kind of one of the issues that has kind of arisen, particularly this morning, but across the whole of this debate, is the extent to which this is a pandemic issue and the extent to which this is an inappropriate or an unlawful issue. It's certainly not a pandemic issue. The pandemic has shone a really strong spotlight on do not resuscitate decisions, particularly given our focus on trying to preserve and protect the right to life over the past 12 months. That really has been something that's been at the forefront of the national kind of consciousness, and we have seen the use of discriminatory do not resuscitate orders. But the question of lawfulness is also really important. A decision not to provide resuscitation is a medical decision, but where that decision is based on somebody's disability, for example, what we have frequently seen is learning disabilities or non-verbal being used as a reason for not resuscitating a person, either at that point or in the future. That's not a medical decision. That is a value judgment about somebody's quality of life based on a discriminatory belief, and that is something which is about the law. And I think that whilst we need to remember that do not resuscitate decisions are medical decisions, they are decisions that take place within the NHS, within our healthcare situation, and those are governed by law, and primarily the Human Rights Act, which bites in all of those areas, which protects our right to life, it protects us from non-discrimination, and also really importantly, it protects our right to be involved in decisions. It's not about necessarily whether an individual consents to a do not resuscitate order, but it is about that individual's ability to be part of that decision-making process. And one of the really shocking findings from our own research over the last 3 to 4 months around do not resuscitate decisions was that when we spoke with over 120 staff members, we had 40% coming back saying that there were assumptions being made about whether a person could or could not be involved in a discussion around do not resuscitate, and the assumption that people just don't have the capacity to do that. And one of the main areas around discrimination within do not resuscitate decisions being learning disability or physical disability or mental disability, as well as other mental capacity issues such as dementia, and also assumptions related to people's age. Now that is highly kind of not just highly inappropriate, but is actually something that engages our legal protections. It is not kind of within the gift of any one decision maker to determine whether or not somebody has the right to be involved in that decision. We all have the right to be involved in decisions about our care and treatment. It comes directly from our Article 8 right to private life under the Human Rights Act. Now, that right can be restricted in some situations and circumstances, but that has to be done on a one-to-one basis, not a blanket approach, which is certainly something we've seen over the last 12 months. And in fact, as an organisation, we have seen that prior to the pandemic. So any restriction of that right to be involved needs to be kind of following the three tests of lawful, legitimate, which is usually to protect the person or the wider community, and proportionate. And that proportionality is really important, that idea of the least restrictive option. What that kind of means in practice is that even when you have a mental capacity assessment which suggests that a person cannot take part in a decision about their care and treatment, they should still be involved so far as possible, and we should still be taking as many measures and actions as we can to determine what they would have wanted in that situation, which might mean talking to their family, their friends, kind of people who were important to them, who can help those medical practitioners understand what that person would have wanted in that situation. And of course there are emergency situations, and particularly now in the pandemic we're seeing increasing emergency situations, but the point is that the law still exists. The point is that we still have human rights, not just even in an emergency situation, but probably especially in an emergency situation. Human rights were born out of war and conflict and emergency, so they have just as much meaning in these times as they do in more ordinary times. So kind of what we've seen come from the CQC report today is kind of overwhelming sort of reiteration of the problematic use of do not resuscitate decisions in the health and social care sector. And I think one of the kind of key messages that we want to share with people is that this is about our rights, this is about our legally protected rights. It isn't just a question of good practice or what is nice to do. It is about our ability to make decisions about ourselves, which includes our care and treatment, and that is something that is enshrined in law, not just in the nice to-dos. So it is about making sure that when decisions within health, social care, social work, those areas are being made that impact us, that it comes from a perspective of what are our legal rights and what are the legal duties at stake here, and how do we make sure that we come to a decision which is lawful, which respects each of our rights.